What is good, guys? How's it going? Got a couple of questions today for you. It started off as me just sitting in the reading room and randomly scrolling through a CT scan, and then it turned into multiple questions of the day. So, starting off with scrolling through that CT scan, this is kind of what I do before I open up any CT. It's called a cine loop. I just kind of hit that button and it scrolls through the stack itself. And then I'm just basically looking at the screen and getting a general idea of what's going on in the CT. I mainly do this for abdominal CTs. I will do it for chest CTs as well. Head CTs I don't. There's not as many cuts through there, and that's more of a fine detail thing. But for abdominal CTs, it's covering basically about lower thorax down into the pelvis. So there's quite a bit to cover. So I like to get a general lay of the land. So what I'm looking for, and this is not for everybody. This is just how I do it. If you want to try doing it, hey, absolutely go for it. I'm not going to say otherwise. But what I'm looking for is basically, is there a flagrant reason for the patient's abdominal pain? Number one, because usually they're presenting with abdominal pain. So is there a flagrant reason? Is it obvious? Okay, that's pretty cool. Are there any large incidentals that I see? Okay, perfect. And then I kind of get the idea, hey, is this a really sick patient? Is this a young, healthy patient? And that kind of immediately tailors me to what I should be looking for. To be completely honest with you, if I scroll through a CT like that, on a lot of these ED CTs, you can pretty much get the diagnosis within that first couple of seconds, and the rest you're basically just filling in the little details here and there. But again, that's just how I do it, so I wanted to take you guys along for the ride. That's why I showed you that CT in the morning, and then as I scrolled through it again, I was like, wait a second, there's actually a couple of things that we can talk about on that CT, and that's why it became multiple questions of the day. So let's start off with the first thing. There's a lot of incidentals on there. We can talk about them if you want. The main incidentals are the ones that I had posted for you guys, and the acute etiology that was causing the patient's abdominal pain, I posted for you guys as well. So let's start talking about those. I think the first thing that we can go over was this image right here. I showed you guys this image and I said, what's going on here? Just for anatomy. So if you look, this is the vertebral body. Remember my general rule of thumb, if the bones are super bright white, you're looking at a CT. If they're dark, you're looking at an MRI. So we're looking at a CT because I'm looking at that, right? What's the bright structure right here? That's the aorta. That's how we know it's a contrast-enhanced examination. You're going to see the IVC over here. Kind of the hepatic veins, they're coming into the IVC right there. You're getting a little bit of the liver. You're getting some of the diaphragm right here. These are the lungs. And then there's this guy right here, right in the middle. That's a hiatal hernia. Okay, you're going to see this commonly. A lot of people that you're reading CTs on are going to have this. That's everybody has it. It depends on how big they are now. A lot of people are walking around with these and they're completely asymptomatic. Doesn't really bother them. Some get massive. I've seen hiatal hernias where basically the whole stomach is in the thorax. They complain of chest pain every once in a while. I have a theory that they're just a little gassy and the stomach is just kind of full of air. And it's pressing on some stuff and they get short of breath, that kind of stuff. So the hiatal hernia, you want to talk about that real quick? I'm more than happy to. There's two basically big categories of a hiatal hernia. You have a sliding type hiatal hernia and you have a paraesophageal hiatal hernia. So the sliding type of hiatal hernia is basically the GE junction or the sphincter down below. So here's the mouth up here, here's the esophagus coming down, here's the diaphragm right here, and the stomach's underneath. So the esophagus comes down, the GE junction, the gastroesophageal junction, should be at that diaphragm level, and then it should go into the stomach down here. So in a sliding type hiatal hernia, that GE junction is actually going to pop up, and it's going to go above the hemidiaphragm or the diaphragms. And then that can cause some symptoms, some reflux. You can imagine if that thing's not nice and tight, and there's not that like musculature from the diaphragm causing that thing to close down when it needs to, the patient could have a lot of reflux. Boards type question: what kind of cancer can happen in the distal esophagus as opposed to the proximal esophagus? If somebody wants to answer that, go for it. That's a popular question they love to ask. And then you have to kind of reason it out. Why does it happen, that specific type of cancer in the distal esophagus? Why is that? So somebody go for it. So we talked about the sliding type of hiatal hernia. Then there is the paraesophageal type hernia, and that's the GE junction is preserved. So remember, we're talking about the esophagus coming down. We have the hemidiaphragms, and then the stomach down here. The GE junction inside the diaphragm right here is actually preserved, but then you have the stomach or part of the stomach actually going to the side of that GE junction, and that's a paraesophageal hernia. It's kind of cool. I've diagnosed one of these on fluoroscopy, had no cross-sectional imaging to go off of, and it's just a unique look to it. Those are not as common as sliding type hiatal hernias. Sliding type, again, we see them all the time, but hey, people do have paraesophageals. There's different types as far as the severity of the hernia. You can have the stomach, you can have pretty much all of the stomach, you can have other organs going in. I think that's a type 4. You can have, I mean, I've seen liver, I've seen a lot of stuff. So that's those are the different stages of hernias. So we got a couple of answers already. So adenocarcinoma distally and Barrett's adenocarcinoma from repeated acidic insult. That's absolutely. So you guys already know all this. That's, again, a popular step 1 type question. So you're going to have this chronic reflux, the chronic acid. It's going and eroding away at that distal esophagus. And then you get dysplasia, and then you get metaplasia, and then eventually you get Barrett's, and then you're going to get, not you specifically, but then the patient can get adenocarcinoma. And then you think about the smoker who gets squamous cell up top. So those are the 2 different types. Again, they love talking about it. So we talked about the hiatal hernia. Sliding type, paraesophageal type, you can have different organs, not just the stomach going up into the thorax. We have mentioned in the past, I've showed you guys an image of a retrocardiac opacity that I wanted you to make sure that wasn't actually the heart, some sort of abnormality. It wasn't pneumonia. And then I gave you a lateral view, and you actually saw it was legit retrocardiac. It was right behind the heart, and it was kind of this bubble. And then you see an air fluid level. That's a diagnostic of a hiatal hernia, a large one sitting behind the heart. If you haven't seen that case, I can post it again, but I believe it's in one of my videos prior. Check it out. Second image that I showed you guys is this one right here. Speaking of old people and speaking of common incidental findings that you're going to see in old people all the time, this, I don't know why. So now that you've seen, where's my hand? Now that you've seen this, I don't know why. This just looks like gross to me. It looks like there's the little balls of feces basically all throughout the colon. This is very common in the sigmoid colon. This is diverticulosis. So I want to talk about the terminology. This is diverticulosis. They're basically little outpouchings. They're false diverticula that kind of protrude through the layers of the colon. Again, sigmoid colon, very, very common. Diverticulosis, it's basically patients who don't have a healthy diet, low fiber, that kind of stuff. It causes some back pressure up in there, and they get this kind of stuff. Now, terminology-wise, diverticulosis, osis. Basically, when I'm doing a report, or if I'm talking to somebody, another radiology colleague of mine, whenever we say osis, we pretty much are talking about diverticulosis. So we just go a little bit of osis, no itis, and that's kind of just slang term for that. Itis, just like absolutely everything else that refers to itis is inflammation. So you have diverticulosis without diverticulitis. That's what we have here, okay? You can kind of argue with me and say, hey, maybe there's some low-grade itis. Hey, sure, there may be some low-grade itis. I can't see it as far as CT evidence. A lot of these patients do have very, just chronic inflammation down there. But as far as CT imaging, I can't really tell you that they do have it. Itis, so different types of diverticulitis. You can have an uncomplicated type where there's just a little diverticula, one little diverticula that is just inflamed. There's a little bit of stranding around there, just like everything else that gets stranding on a CT image, that can get stranding as well. So it can be a little bit of stranding. It's uncomplicated, good to go. Give them a little bit of antibiotics, off they go. The other thing, you can have complicated type diverticulitis. So if it's complicated, you obviously have complications because of that. What's the main complication that you worry about? This thing can perforate. So you can have perforated diverticulitis. Then you check for free air. Please tell me from yesterday's talk, how do you check for free air on a CT image? You don't just scroll through on this window. This is not the window that you check for free air. Yes, you can find free air, but it won't be as obvious to you. So you look at the lung window, just like you're gonna go look at the lung parenchyma and everything gets all whited out. You use that window and then you scroll down into the CT and then you check for the free air. Free air is not just flagrant kind of air just rising to the top of the abdomen. Sometimes it can be just little specks here and there, but that's all the surgeon needs to know to tip them off that this thing has actually perforated. So you have perforation is the main guy. You can have an abscess as well. That's terrible. IR purposes, if anybody is interested in IR, how do you drain this thing? Well, you're going to do it percutaneously. We're going to use CT. We're going to use ultrasound. We're going to get in there, drop a drain in. Usually we like to drop drains in fluid collections that are larger than 3 centimeters. That's a general rule of thumb. We have done it for collections that are smaller, but that's what we like to do. We want to make sure it actually is an abscess. When you have diverticulitis and you have a thick rind around some sort of fluid collection, an enhancing component to the wall, yeah, it's an abscess. So we'll drop a drain in there. What else as far as diverticulitis? You can have diverticula in other portions of the bowel. Yes, a common place that a commonly seen uncommon area, if that makes sense, for a diverticulum is the duodenum. So if you're scrolling, everybody knows I do this, right? This is the duodenum right here. And in the second portion, which is right about there, you'll see this little outpouching and it'll be full of air. And you'll go, I don't know what this is. It looks like a weird little bubble next to duodenum. Well, yeah, you can have a duodenal diverticulum. That's, again, a commonly uncommon place. And it may be even common now because we see it quite often. You can have it. I've seen diverticula in the small bowel. I found that weird. But I have seen it in the small bowel. I think that's pretty much it for diverticulosis. The last, what else did I show you guys? Oh, yes, let's go to this. I showed you this image right here, I believe. This guy right here. And I said, what's going on right here? So I want you guys to now put yourself in the driver's seat. You have a patient coming in and they're complaining of abdominal pain. A lot of these patients, it's kind of just vague, generalized abdominal pain. They can't really pinpoint it. But if they can pinpoint it and they say right lower quadrant, immediately you're starting to think about the appendix. Appendix. You need to absolutely find the appendix and rule out that the appendix is not inflamed before you go to other options, okay? I have seen something that on CT we called a tubo-ovarian abscess. It looked like a TOA slam dunk off of CT no matter what. Then they weren't exactly convinced. They got the MRI afterwards. And then in the MRI, the high resolution sequences, we could see that the appendix that we thought we had seen on CT, but we didn't really, you could see that kind of, it just basically burst open and it was a periappendiceal abscess and it was acutely inflamed. So you have to find the appendix, okay? I dictate this all the time. If for some reason I absolutely cannot find the appendix on a CT examination, I will put that caveat that, hey, although I did not find the appendix, there were no inflammatory changes in the right lower quadrant. So that kind of tips off the clinician that, all right, you know what, they didn't find the appendix, but hey, nothing's inflamed in the right lower quadrant. Hey, guess what image this is? I know it's going to be flipped on the screen, but this is the right lower quadrant. So look, hey, there's some inflammation in the right lower quadrant. You're going to ask me, Amrit, how do you know that this is inflamed? Well, let's go down here. This is what fat should look like on a CT. I've said this many times before. If you don't know what fat looks like on a CT, well, hey, guess what? Go to these soft tissues. Everybody's got fat here. Yes, I got plenty of fat right here too as well. So go look here. This is what fat looks like in the sub-Q tissues. Compare it to the intraperitoneal fat. Yep, pretty similar. Now let go over here to the right lower quadrant. That's not similar actually. So you have a nice comparison right here. Good fat, bad fat. So you got some inflammatory changes in the right lower quadrant. You have a lot of stranding. I'm already getting suspicious for acute appendicitis. The other thing that I wanted to show you, let me see if I can see it. This image I don't think I provided it to you guys, but what is this right here? So this is all the right lower quadrant again. Remember, this is the image that I just showed you. By the way, this air right here, this is not intraluminal air. I have not seen a lumen that looks like this in this right lower quadrant, so I'm already concerned that this is perforated. I'm looking over here. What is this bright structure sitting right here? So you have to be very concerned. We did a live on this before. In a child who has a KUB that's done, remember that X-ray that's done of the abdomen, they're complaining of abdominal pain, and you see a radiodense circumscribed structure in the right lower quadrant, your initial concern is acute appendicitis in a child, okay? So that's that whole thing. It's just kind of recapping what we talked about before. Just to go on a side tangent, because you know I love to do it. You are concerned about acute appendicitis on the child. What is the next appropriate study that you want to order on that child? It is an ultrasound. You want to order an ultrasound. You don't want to order a CT because it's got radiation. My institution, we actually go a lot straight to MRI. We have really quick MRI sequences. Our MRI is beautiful, so we do it quite commonly out of the ED. But you want to use an ultrasound, pretty much that's the standard of care everywhere. So that's the next step. Now, this is not a child. How do I know that? Well, a child's not going to have that much diverticulosis, and I'll show you another reason why. And a child, I'm sure, is not going to have that hiatal hernia like that. Yes, weird things happen, but no, this is not a child. So the patient was complaining of right lower quadrant pain. They did a KUB. Basically, all I'm going to tell them is it's a non-specific bowel gas pattern. I don't see any frank free air. So I'm going to say, hey, you know what? Get the CT scan. If anybody asks me, should I order the CT scan with or without contrast? If the patient has no renal impairment or you're concerned about renal impairment, that's a whole different, by the way, conversation that I'm going to have with you guys at some point. But standard of care right now, if you're not concerned about renal impairment, blah, 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 or if the patient, you're not concerned about renal stones, just get the contrast, please. It makes my life a lot easier. It makes any radiologist who's reading this study a lot easier. So get the contrast. So that's the number one. So we did the contrast enhanced CT, right lower quadrant, find the appendix, find the appendix, find the appendix. I can't stress that enough. The appendix will have a habit of screwing you over if you have not found it. If you haven't found it, again, just to recap, make sure that you say there are no inflammatory changes. In our case, there are inflammatory changes. So that bright structure that I was asking you guys about right here, somebody mentioned fecalith. I like that. That's a good, it's a very good guess, and I'm sure there's a fecalith hidden in there as well. The fecalith wouldn't be that bright. This is an appendicalith. So just to terminology, but the bottom line is, what is a fecalith and what is an appendicalith? You have to remember, how does appendicitis happen? The appendix is attached to the colon. It's a free structure. The intraluminal area is going back and forth. Feces is going in, it's coming out. It's kind of swash back and forth. What happens if something, here's the cecum, here's the appendix. What happens if something gets lodged right in the middle? Well, this builds up, this fluid inside the appendix. It can't get out. Bacteria gets in there, it gets inflamed, it's appendicitis, it gets too pressurized, blah, 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 and it bursts, and hey, you can get an abscess. So that's what an appendicalith can do. That's what a fecalith can do, both of those things. So bright structure, bright structure, bright structure. You're looking at an appendicalith. I showed you that air should not be there. This is a perforated appendix. Here is the last image that I want to show you. This was on the CT. Anybody went back to the CT to scroll down. This is this juicy appendix right here. Somebody asked me, what is the size cutoff of the appendix on CT to start thinking about acute appendicitis? 6 millimeters. So you're looking at the appendix, you measured it to be 6 millimeters, 7 millimeters, 8 millimeters. Now you're thinking that the appendix is acutely inflamed because the size is too big. So you're putting together three things now. You have an appendicalith, you have right lower quadrant stranding, you have an appendix that's way larger than 6 millimeters, and you have free air. The slam dunk, slam dunk, slam dunk. This is acute appendicitis perforated, so that's where I'm going with this case. Cardiology on call, thumbs up. Thanks, man. Appreciate it. The next thing that somebody did mention, they mentioned a mucocele. Has anybody heard of a mucocele before? This is a cancer. This is a malignancy that can be in different areas, but when we're talking specifically about the appendix, yes, it can hide in the appendix as well. Always killing the lab game. Hey, thanks, man. I appreciate it. I'm trying to keep up with you, man. So the mucocele, the type of cancer, can hide in the appendix as well. And if you have a juicy appendix, there's no stranding or anything around it, but the appendix itself looks like fluid attenuation. It looks simple-ish fluid, maybe a little bit brighter. It's juicy, it's thick, and it looks like a sausage hanging down there. Be careful that this may be a mucocele. You want to characterize that further. You may need to get an MRI. MRI will have different characteristics that we can go over at some point. But this is something you want to tell the surgeon, because that's not just a straight appendectomy. Remember this, please, please, please. That's not a straight appendectomy. If you tell the surgeon, you're like, hey, I think this is a mucocele, or if you just forget to even mention that, you're like, I think this is appendicitis, he's got a juicy appendix, go take this out. Well, they're going to go in there and they're going to cut the appendix off and they're going to try to take it off, and you can have some of that mucin seep out of there and it can go into the intraperitoneal space. Guess what? You just gave this person Mets into the intraperitoneal space. You don't want to do that. So actually for this, you got to do a hemicolectomy. Chop it off, take that whole part of the colon off, and you want to make sure that you don't rupture any part of that mucocele. So remember that. What's the next thing that I wanted to talk to you guys on this scan? What was it? Oh, what is this real quick? So we talked about this image, right? I showed you the appendix right here. What is going on right here? So this is bilateral hip replacements, okay? So you have a hip replacement, you have a hip replacement. Look at how bright these things are. This is so, so bright. And then what is this right here? So this is artifact. You're gonna get this type of artifact on CT whenever metal is around. There are some other things that can happen too that cause this, or some other things that can cause this to make this happen. But metal, if you see metal, you're gonna get this streak artifact. It's basically your photons can't get through, and there's a lot of physics behind it. You can have beam hardening. Sorry, time for water. I'm surprised I haven't drank half a bottle by now. So get used to seeing this streak artifact. It can kill you when it comes to, not obviously like literally, but it can kill your dictation when it comes to looking for stuff. Like right now, I can't tell you anything about this bladder. I can tell you about the bladder, it's like up to here, but can I tell you that there's something sitting in the bladder down here? No, absolutely not. Can I tell you about the prostate? No, absolutely not. Seminal vesicles? No, I can't. So it can really mess you up when it comes to things. When it comes to the head as well, you're gonna do a CT head non-con, and you can check for a stroke, but the dude has like a coil in there, or he's got some sort of external device. The streak artifact is just gonna mess up your dictation. So that sucks. This is safe. If you ever have to wonder, by the way, this is safe to go into MRI. Was there anything else I want to talk to you guys about? We talked about all the diverticulosis. We talked about mucocele. For a hiatal hernia. We talked about the cancer. We talked about the reflux. We talked about all that stuff, the two different types. What is a treatment for it? You're going to want to obviously give these guys PPIs. Do whatever you need to, the H2 or second generation stuff. Do whatever you need to control that acid. If that doesn't work, something called a Nissen fundoplication. It's a surgical procedure where basically they wrap a little bit of the stomach around the distal esophagus, and that usually does it, but sometimes those can open up again and cause a bunch of issues there as well. Whew! All right, questions. What do you guys got? This was not meant to be a case of the day. This was just meant, I don't know, I was just having fun. But this turned into a good case. I got a lot of really good responses, and I appreciate you guys looking at that video over and over again. Man, some people are just killing it, finding all those incidental findings. So that was awesome. Anything else? We good? Give a couple of seconds. Somebody's typing something up right now. Otherwise, we're about to pick this up again tomorrow. Tomorrow, I'm thinking about live streaming it. I'm giving a talk to the medicine residents. It's going to be on PE studies, what to order, when to order, difference between submassive, massive, what can we do about it? If you want to know what we can do about it, I will tell you as well, but I'm thinking about streaming that tomorrow. We'll see. All right, guys, I appreciate today's discussion. You guys were awesome as always. You guys have great comments, great questions. Until then, I will see you guys.